I found there's about a 30 to 40% rate of guys who do sub-Q who get like a welt, like an uncomfortable lump and a bump. Other guys will notice they get a reduction in benefits, and they'll often see a drop in their serum levels by about 30 to 40%. There is a huge unmet demand for hormone replacement therapy in Europe and other countries. Successful clinic operators from countries like the US will see the opportunity to expand and then set up operations in other countries. People all over the world are suffering with hormonal issues. I think it's more prevalent in Western countries because of the diet and lifestyle factors, but it is still prevalent globally, and I see that demand absolutely not only growing, it's already grown, and the demand is not being met.
Guys, when we started the Unscripted Podcast, we told you we were going to bring in some of the world's experts in the whole optimization space. And today's guest is a deliverance on that promise. We have today a very special guest. He is, everything. He's an author, he's a consultant, he's a speaker, and an entrepreneur, but all of it is really in the optimization space, specifically HRT. This is the man, the myth, the legend, Dave Lee. How you doing, brother?
Thank you very much, and thank you for that very kind intro.
What did I miss? I know you're always working on different things. Did I miss anything in there?
That's a pretty good summary. That's probably a better summary than I could have given myself. I'm primarily an educator at the moment. I've kind of gone more into educating than health coaching, just so I can reach more people. I can only see so many people in a day. And that's probably been the most exciting part of my career, is now taking what I've done, learned, and practiced in the trenches and teaching and managing doctors and nurse practitioners all over the world how to deliver that to their patients, so that way it can reach more people, which I think is amazing.
Well, this is perfect. Yeah, this is perfect. That's the audience that we want to talk to. And so this is awesome. And I hope, folks, you really tune in, because Dave really is one of the experts in this field. So how did you said everything that you've kind of learned over the years. How did you get into this wild world of hormones and optimization?
Yeah, it's definitely not a field I ever thought I would be in. I stopped doing science in high school when you could stop doing it, because you can't bullshit your way through science like you can with other subjects. So I was a professional musician. I was in a band. I got a degree in music, and I ended up getting another degree in commerce, doing marketing. And I was running a digital marketing agency in my early 20s. I was doing reasonably well. It was right when the Facebook funnel thing launched. So, that was kind of kicking off. And one day I woke up, and it was like I'd spun around on my office chair 50 times, and I fell into my wardrobe and was very scared, went to the doctor, and it took years for that to get diagnosed. So I had this severe dizziness and vertigo for years straight. I had to close my business down, move back in with my mom. It was very traumatic. And eventually they told me that they worked out what it was. It was the inner ear nerve that's kind of like the gyroscope of the ear that tells you where you are in space, was damaged on the right side, and therefore I would never recover. And if it wasn't for initiating testosterone replacement therapy, I probably would have believed that. But I had this mentality, and maybe because I grew up in punk rock, of F you, if you can't solve it, I'm going to work it out myself. So I went back to university, managed to get a postgraduate diploma in science. I had to do a bunch of stuff to be able to do the lectures and have things transcribed to me. It was very difficult. And when I was entering into my master's in neuropsychiatry, I wanted to learn how to heal the brain. I realized that course was mainly about how to drug people, and that wasn't what I was interested in. But the study of hormones and the work I was doing with rehabilitation, mainly with peptides at the time, this was back before peptides were trendy, so BPC was very underground, it was very novel. And once I recovered from that and was able to heal myself through, learning how to study science and apply it, everything else seemed very superfluous. So I started doing this full time, just helping other people with not so much playing the role of a doctor, but when you're seeing 5 or 6 different specialists and they're not communicating, I wanted to be the person in between that to help people go through this journey, because I didn't have that person there for me. So I wanted to be that person that I needed when I needed him when he wasn't there. And that ended up taking off, because for the first time in my life, I was truly passionate about something that made a difference. And I just attacked it head on with everything I had for the last 6 or 7 years. And that's taken me to a place where I've been able to recover my health, but also build a fantastic life for myself and help many other people in the process.
Yeah, that's beautiful. And I know you literally work around the world. I mean, I know you're Australian by upbringing, and you're over in Eastern Europe now. But you and I met at Ali Gilbert's Silverback Summit here in Arizona, and you travel around the world talking to folks. And I'm just curious what your take on the state of the hormone replacement industry is today. globally?
Yeah, it's very interesting. When I first started in the field, no one knew what TRT was. I think there was one book written by Jay Campbell at the time. There was no YouTube channels about it. It was very underground. And my original interest was raising awareness for it. And, I can't say that I was directly responsible for how mainstream this has become, but that's now done. So I'm very happy with that. But it's taken me into this new area, which is that everyone now knows what it is, but no one's doing it right. And
Yes.
when hormone replacement therapy is done, because we're hijacking a very integral internal system in the body that's usually self-regulated, if you don't do it right, you can cause equal harm and good, or you can cause more harm than good. So I've always been into communication. I was previously a music teacher for a little while. I like teaching, and I've seen a big demand for teaching not just practitioners how to do it right, but patients, allowing them to understand what's going on with their health, so that way they can have an informed conversation with their provider and seek out the people who are doing it right. It was very fascinating coming to America, not last Silverback, the Silverback before. I landed in Vegas for the Olympia, and I was in an Uber from the airport, and there was an ad for TRT on the radio. And I was like, this is mind-blowing. And I said it to the Uber driver. I'm like, is this a thing? And he's like, yeah. And I was like, in Australia, there's maybe 5 or 6 TRT clinics. In Eastern Europe, where I'm based, there's one, which is my clinic. And it seems like in the US, when I was staying with Ali, there was more clinics within a 10-mile radius of her house than all of Australia and Europe combined. So the problem that I saw when I was at the Olympia and I was, running this education seminar is that the stuff that I was teaching that I consider the basics was mind-blowing and revolutionary to doctors in the room who were prescribing it to patients. So I was kind of disturbed by how appalling the standard of care is for TRT. And I would wager that 90+% of TRT clinics and providers don't intrinsically understand hormone replacement therapy at all. They're just following a handbook. And I think the state of the industry, the standard of care is extremely subpar, and there are only a minority of people who actually know how to do this right.
I couldn't agree more. And that's actually why we have this channel. That's why we started our company Scripts, is because I was asked to join the board of a large TRT clinic nationwide. And I saw the same thing, brother. I saw the same thing. I was like, how are we doing this? And we're treating thousands of patients, and we're not doing it right, and so trying to raise the bar. And so what you're doing is so important. The piece that I would say to that is my TRT journey started about 10 years ago. I had previously been diagnosed about 5 years before that with hypogonadism and, had the testosterone level of an 80-year-old man, but it was so taboo at that point, and really nobody was doing it, that I just didn't want to go down that road. Right. And so even, 5 years later, which is now 10 years ago today, it was still very taboo, very weird. I tell people I had to go into a clinic. They had to inject me, every week. It was like almost like going into a porn shop. You kind of snuck in the back door because it was really taboo. But, it's changed over the last 10 years. In countries like Australia, countries that you've been involved in, do you see that potentially happening over the next 10 years?
Yeah. I think as the globalized world more kind of takes off, especially over in Europe, like it's been very interesting for me. I've been living in Lithuania for 5 years, but I was kind of coming back and forth for the 3 years prior. And you see the westernization of Eastern Europe happening quite prominently. And I think there's good and bad that come with that. But as these clinics and practices become more popular in the US, the demand eventually will grow globally. And over here in the Baltics, for example, when I moved here and I meet people and I speak to people, everyone wants to know about it. Because if I say, I work with TRT, even people who don't speak English as a first language know what that is. 5 years ago, no one would have known that. So it is absolutely taking off. When I was first starting in Australia, it was all very underground. I mean, people just basically had to find the odd GP here or there who would do it. And it's something that when we launched the clinic over here, we're now about to enter into Scandinavia, which will be the first provider in Scandinavia, which is going to be amazing. It's been a very difficult legal battle to make that happen. There's a lot of regulations there. But there is a huge unmet demand for hormone replacement therapy in Europe and other countries. And what I think is going to happen is successful clinic operators from countries like the US will see the opportunity to expand and then set up operations in other countries. And I think that that's going to be fantastic because people all over the world are suffering with hormonal issues. I think it's more prevalent in Western countries because of the diet and lifestyle factors, but it is still prevalent globally. And I see that demand absolutely not only growing, it's already grown, and the demand is not being met.
Couldn't agree more. We had a guest a couple of weeks ago who is bringing his clinic from the U.S. over to Dubai and kind of working through the red tape there. What in these countries that you're moving into, what do you see as the biggest, we'll call it obstacle as it relates to the nuance of regulations, et cetera? I know Australia is pretty regulated, but some of these other countries.
The nightmare with Eastern Europe is that every country has a different policy regarding medications being sent from abroad, even within Europe. So there are standards for the European Union, but then every country is different, and then every country changes those laws quite dynamically, and they don't tell you about it. So it seemed like a much easier operation when we started the clinic to say, okay, we want to service all of Europe. And then it turned out that there's a lot of countries which was just like, this is just more hassle than it's worth. And It would be fantastic for someone to set up something locally within the border, but it's the extremely harsh regulations on testosterone, because testosterone is not scheduled in the same class as the other hormones. So estrogen, progesterone, thyroid, these are scheduled lower, whereas testosterone is often scheduled at a higher level, similar to opioids or prescription stimulants and things like this. So the different countries, different bureaucracy around things is the biggest nightmare. So for example, we've been really wanting to work with Scandinavia for a long time because there's a huge demand there for it. But even though there are laws saying that if you're prescribed it in Europe, you can have it sent to Scandinavia, it gets stopped at the border. So the way that we had to work around that was we had to build our own compounding pharmacy in Latvia so that we could then send the medication to the patient's pharmacy in Scandinavia and have a relationship with them. And then it can be prescribed, well, it can be fulfilled from the local pharmacy. So I think at the moment, though, those kind of options are available for people. They just haven't been explored yet because there's a bit of red tape, but there's enough red tape that you can make it happen. So it's those regulations that are difficult, but they can be worked with, but that's the biggest challenge. Yeah.
Having educated so many clinicians and continuing to do so both here in the US as well as internationally, what do you see as the biggest gap as far as where are they falling short today?
I think there's two areas. I think the first area as a whole is that Western medical doctors are not trained in understanding the body as a series of interconnected systems. It is very obvious and quite stark when you're working with doctors who haven't chosen to take additional education on their own accord that they don't know anything about nutrition. They don't know anything about preventative health. They don't know anything about health optimization. They only know how to treat acute sick disease states. And a lot of the time, those processes and medications are not ideal. So I see a lot of the time now, patients are going to see health providers, not because they're acutely sick and dying, but because they want to be healthier. And doctors are not able to facilitate this because that's not what they're trained in. So I think that's one big factor. And one of the things that I spend a lot of time teaching the providers who I work with is the importance of understanding the patient's diet, lifestyle, stresses, comprehensive blood work as a whole. Because when there are side effects on TRT, if the protocol's done right, a lot of the time the side effects are coming from lifestyle factors. And when you can educate them on not just saying this is caused by that, but this is how this is caused by that, and this is how interventions work to resolve it, if people intrinsically understand something rather than just being told what to do, they tend to feel like they are making that decision to do that rather than just following guidance. So I think that's very powerful. The other thing, the second point that I think that was the most obvious to me at the Olympia is that a lot of practitioners who prescribe testosterone don't really understand what testosterone is or what it does. And they also don't understand what's called the pharmacokinetics of the medication, meaning that if you inject cypionate or enanthate, how that drug metabolism works over time. And one thing that I've been really trying to educate on is that when it comes to hormone optimization, we need stability. Stability is the number one factor because it's not just the level, it's the direction that it's moving. And when it comes to maintaining stability, when it comes to medications, you have to redose it at the peak. So if you want to stay caffeinated, you wouldn't have a coffee and then have a second coffee 8 hours later. 8 hours half-life. But if you wanted to stay caffeinated, you'd sip the coffee at the peak. That's how you'd keep it steady. So hormone replacement therapy, that people often say, well, enanthate or cypionate has a half-life of, this period. So if you redose it, twice a week or every week, you'll be able to maintain stable concentrations. No, you keep some in the body, but there's no stability there. So there's a lack of understanding around the pharmacokinetics and how the pharmacokinetics impact the outcome of treatment, because optimal testosterone levels are important, but stable optimal testosterone levels are what delivers the best result.
Absolutely. No, you nailed that. I know you're a big fan of frequent dosing throughout the week, whereas, in the old days, we were told to inject once a week or every 2 weeks, right? And call it a day. I know you're a fan of dosing as much as every day. Talk about that. Why?
Yeah, my first prescription was 250 milligrams every 2 weeks with an 18 gauge 2-inch needle in the quad. And I remember doing that and sweating and shaking, and I had to kick everyone out of the house. And I think I stuck the needle in like a third of the way and it bled everywhere. And so one component of that is when you're injecting less oil, you can use a smaller needle. And unless you're a masochist, using a smaller needle is ideal. So that's one factor. I'd rather inject a tiny little baby insulin syringe than, stick a big needle in my leg once a week. Even if the outcomes were the same, but they're not. So when it comes to the frequent dosing, I used to sell mobile phones when I was at university. I used to work at a phone store, and this was back when like the iPhone first came out and the Samsung Galaxy S2 and these kind of things. And this was back when you could pull the battery out, back in the good old days. So if someone came in with a problem with their phone, we'd say, have you tried turning it off and turning it back on again? Have you taken the battery out? And what that would do is that would basically reset if there was a bug in the software. And most of the time it was a bug in the software. If that didn't fix it, it was a hardware issue. We had to take it away to get it fixed. When it comes to hormone replacement therapy, the easiest troubleshooting version of taking the battery out and putting it back in is increasing the injection frequency. Because when it comes to enanthate or cypionate, this is basically a deliberate biological bottleneck, meaning that testosterone, if you just inject straight testosterone, has a half-life of minutes, so it spikes up and out very quickly. So they attach it to what's called an ester, which allows it to basically bottleneck in the liver, and the liver cleaves the ester molecule from the testosterone to make it bioavailable. So when we're looking at that process and we're basically capitalizing on this bottleneck, what we want to do is allow the body to have these stable levels over time, which is extremely important in delivering the results that we're trying to achieve from the therapy itself. So if we're looking at doing a daily injection of testosterone, it can seem quite off-putting because people go, well, I don't want to stick a needle into my body every day. And I completely understand that. But when it comes to delivering the optimal outcome of the treatment, if someone can go, hey, if I'm doing 2 shots a week, for example, and we don't know exactly how each individual person metabolizes the ester because we don't fully know which liver enzyme is responsible for metabolizing it, so we can't run genetic testing. But what we do know, and I've done a lot of peak and trough testing on guys, is that if I get a guy who's doing twice a week, run a blood test, let's say 3 or 4 hours after his injection versus right before he does his next injection 3 days later, sometimes I'll see that level cut in half in just 3 days. Other guys, they'll be pretty stable. So there's a lot of individual variance in how quickly people metabolize this ester. So one of the really good troubleshooting approaches is saying, have you tried injecting more frequently? And there's a massive benefit from going from 2 injections a week to 3, and that's only 50% more shots. So if you're doing something twice a week with a little 27 or 29 gauge needle into the shoulder, half-inch tiny needle, I often joke that diabetic little girls do it every day. So they have to do it just to survive. So yeah, you can do it. And if you're doing it twice a week, you can do it 3 times a week. And that, I think, is probably where the point of diminishing return sets in for a lot of people. Because going from 3 times a week to daily is now going from 3 injections a week to 7. That's much bigger than 2 to 3. But For people particularly who have metabolic issues, so people who are overweight, people who have high body fat, people who aren't as healthy as they need to be, and they're working towards that from the TRT and everything else they're doing, a lot of the time the conversation I have with guys is I say, do it daily for 8 weeks. You can do it for 8 weeks. And if that causes your side effects to go away and for you to be stable, then problem solved. And most of the time they come back and say, look, I can use a smaller needle now. I can use a 29 gauge because I'm only pushing a little bit of oil out. It's part of my morning routine. I can wake up, put a YouTube video on, draw it out, inject it in a couple of minutes. And, it's pretty cruisy. And a lot of the time that stability resolves the issue. But if it doesn't, it means that there's other issues going on. And that's when we need to look at comprehensive blood work, lifestyle, all of those factors, because injection frequency won't solve an issue with alcoholism or terrible diet or lack of exercise. But it's an easy thing that people can do that's a very good first line of troubleshooting. And then if that doesn't resolve the problem, then we can look into more comprehensive things.
That's beautiful. And I think people, when they think of injecting, they think of the big harpoons, the 18 gauge needles that you and I both started on, right? And so I do like the idea of using smaller needles, microdosing throughout the week. Is there a benefit? Well, is there not a benefit? We have some clinicians who obviously prescribe intramuscularly injecting, and we have some that suggest subcutaneously. Can you talk a little bit about that?
Yeah. So for reference, this is the size needle that I use. This is a 29 gauge half-inch needle. The needle is so small you can barely see it in the camera. So this is a tiny little needle. If I was wearing a t-shirt, I'd stick it into my shoulder to prove a point. When we're looking at the subcutaneous versus intramuscular injections, if the outcomes were the same at scale, then it would be subcutaneous, just from a comfort standpoint. It's more comfortable to stick a needle in the belly fat than it is to stick it into the muscle. Now, with that said, into the deltoid, there's no nerves once you break the skin, so it's more just it's a very kind of mild difference, but it would absolutely be more comfortable to do it subcutaneously, for sure. The problem with subcutaneous injections is that at scale, they don't consistently work for 100% of the population. And on an individual level, if someone's already doing subcutaneous shots and their levels are great and everything's working, keep doing that. Awesome. But if you're looking at running a clinic of 1,000, 2,000, 5,000 patients, and you recommend that every one of those patients does subcutaneous injections, I've found there's about a 30 to 40% rate of guys who do sub-Q who get like a welt, like an uncomfortable lump and a bump, like a mosquito bite. And even if they don't, other guys will notice they get a reduction in benefits, and they'll often see a drop in their serum levels by about 30 to 40%. The challenge with subcutaneous injections when it comes to an oil is that typically when we prescribe subcutaneous injections of things like peptides or insulin, they're an aqueous solution, they're in water. So that, if you imagine the subcutaneous fat layer, the way that it gets into the bloodstream is kind of like a shower drain with really, really tiny little holes. So when you're putting an oil in there, it doesn't enter the bloodstream as quickly as it should. Now, people will go, well, that's good. It means it doesn't absorb as quickly and, you get more stable levels. That's not how it works. It bottlenecks in the liver with the ester. So my hypothesis on this is that the reason why they get the reduction in levels is that the immune system creates inflammation, which is the swelling, and it breaks down the testosterone before it enters the bloodstream. So in a perfect world, I would love subcutaneous injections to work, but at scale, 100% of guys respond well to intramuscular injections. But if someone's already doing subcutaneous injections and it's working, great. But from a clinical standpoint, I don't recommend it personally. But with that said, the carrier oil is a big factor. So in Australia, the primary carrier oil is cottonseed oil or castor oil, which is very thick.
Ooh, yeah.
We compounded MCT oil so that it's thinner, and it's also less immunogenic for people who have reactions to it. But in the US, the standard oil is either grapeseed or sesame. And when you look at the studies on subcutaneous testosterone administration, where it works equally well to intramuscular, it's done with sesame oil, which is much thinner. So it doesn't, and I had a theory that if everyone used thinner oil, it would work for everyone many years ago. Turned out not to be true, but that is a variable in the equation that does help. It's a thinner oil, works better subcutaneously, but at scale, intramuscular is the way to go. But if someone's doing subcu and it works for them, great.
Yeah, at Scripps, we offer the grapeseed, but MCT is becoming more and more popular with clinicians. They just, to your point, less side effects, less the allergenic reactions, and it's just smooth. It's easy. It's it's high quality, and so we're getting a strong response from that. Is there any benefit between cypionate and enanthate?
It's a great question. So I relate cypionate and enanthate to Coke and Pepsi. They're basically the same. People will have a preference, but if you love Coke and there's a restaurant that only has Pepsi, you'll have Pepsi. Now, Diet Coke and Pepsi Max are much different. I mean, Pepsi Max tastes far better than Diet Coke. But so when it comes to cypionate and enanthate, they are so similar. There is one molecule different in the ester, and cypionate, as a result, has a slightly longer half-life and a slightly lower and shorter, it has a smoother peak to it. It is really comparing Coke and Pepsi in terms of preferences. It's basically the same. And most of the time, it's similar to the Coke and Pepsi thing. A restaurant will either have one or the other. So countries typically, like in Europe, most of the time it's enanthate. In Australia, it's mainly enanthate. In the US, it's mainly cypionate. They are basically the same. In Australia, at my clinic, we can compound both. So because the cypionate has a slightly longer half-life, then we're going to gravitate towards that. If they're both the same price and they're both the same availability, we're going to prefer that. But at the end of the day, they are so similar that they're basically the same thing. So they're virtually interchangeable.
When you're injecting every day, is there any use case in which propionate would make sense?
So this is also a point that I've seen come a trend in the recent years. And I recently did a podcast with Dr. Todd Lee, who has a very harsh but very true take on it, which I find very entertaining. Some people get a bit upset by it. But the issue with propionate is that, so in theory, when guys are looking at using propionate as a daily shot, they're saying that this variance in terms of a more significant peak and trough, because it's a much shorter half-life medication, is more in alignment with the body's natural rhythm of having variation in testosterone over 24 hours. That part is true. The testosterone levels do fluctuate by about 30 to 50% over the course of the day. The problem with propionate is, one, it's typically 100 milligram per mil, so you're looking at minimum twice the amount of oil. But secondly, you're now tethered to daily injections. So if you're doing daily injections of cypionate or enanthate and you're traveling or you forget your vial or whatever, you've got so much of that stuff banked in your body that you're not going to feel a difference. Even if it's a day or two skipped, it's not going to be a problem. If you skip a day or two of propionate, your levels are crashed into the gutter. So you're tethered to using a product with double the amount of oil. But the thing with the spike is that spike actually starts just after midnight. So if you wanted to mimic the body's natural rhythm, you need to set your alarm for midnight to do your shot. But because you're creating a rhythm that's not part of the body's natural operating system and biology, there's no benefit to that level of flux. And the amount that it fluctuates over a 24-hour period is very significant, because a lot of the time when people are talking about half-lives, they conflate something called mean residence time. So propionate actually has a half-life of just under a day. It has a mean residence time of 3 to 4 days. So by the time you're doing your shot 24 hours later, your body's eliminated more than half of that testosterone from you. And this is a much greater variance. Todd refers to it as like a sawtooth kind of graph, which is a very good visual representation of it. Whereas when you're doing a cypionate shot daily, because you still get a 24-hour spike, you are actually getting some degree of variance over 24 hours. And if people don't believe me, get your blood test done after 2 hours and 24 hours, and you'll see that there is a variance in levels. So I don't see a benefit to propionate, and I think that it is it's an inferior treatment option.
You know, coming from the bodybuilding and fitness world, I had several coaches when I was, well, we'll call it self-diagnosing my testosterone journey. You know, they recommended injecting. I was trying to bring up my delts, and so they recommended injecting my delts, thinking there was some localized benefit. Is there any truth to that?
So again, I'm going to reference Todd on this because he's completely correct. there is not a local benefit, but arguably in what he proposes, which makes a lot of sense to me, he's got a biochemistry background and I've got a biomedical science background. So when I'm listening to it, I'm like, this makes sense. If you were to inject testosterone, let's say into the delt and go do a deltoid workout, it would cause more blood flow to the delt, which would cause that testosterone to distribute around the body faster and be uptook into the system faster. So that would be the only benefit of doing an injection prior to working out, is that the testosterone would hit your system potentially more quickly. But if you're on a stable long-term protocol and everything's kind of been dialed in for a while, I don't think it would make very much of a difference. But from a bodybuilding standpoint, I mean, this is why bodybuilders use like orals before a workout, because they get that anabolic spike, which they also get a dopaminergic spike, which, you know, one thing that I learned a little while ago, because I was really into like pre-workouts and supplements when I was like 18, 19. One thing I learned a while ago was that these are just over-the-counter supplements designed to replicate the effect of taking pre-workout oral anabolic steroids. And that made a lot of sense to me, because I can imagine, it's not something I've personally done, but I can imagine when bodybuilders take some strong orals before they go train, they probably feel like an absolute savage in the gym.
Yeah, absolutely. Creams. What's your take on creams? I was actually I was on a podcast with Nico Mesla, who runs HRT University here in the U.S., and he's a big fan of creams. I'm curious about your take on creams and use cases and potential drawbacks to creams.
Huge fan of creams when they're compounded properly and when they're used right. So at my clinic here in Europe, because of the laws internationally with injections being way too difficult, we actually only offer cream. At Primal Zone in Australia, we offer both. And I think the ideal world is for practitioners to have injectables and cream in their toolbox. When it comes to cream, the most important thing about cream that people need to understand is that the 2%, 5% creams that are commercially available in pharmacies are trash. Some people will hyper respond to them and get a good result from them. Absolutely. But exceptions don't disprove rules. The problem is that the amount of cream you'd have to put on, it would be like when growing up in Australia, like in summer, like you have these memories of your parents just slathering you in sunscreen, and there's so much, it doesn't rub into the skin and it's gross. That's kind of how those creams work, because you have to use so much of it, and the bioavailability is very poor. It's very difficult to get a hormone, rub it on the skin and get it into the blood. So when a cream is compounded, it's compounded in a base, and there's 4 good bases available, which is the HRT base, the liposomal base, also known as lipoderm, and then there's a Trevis, and there's a Versa base. And these all use slightly different, very advanced technologies. So for example, the liposomal one, they actually break open the liposome, put the testosterone molecule in there, seal it back up, and then it allows you to cross into the blood from the skin. Just fascinating. Turns out it was a very expensive machine for us to get. So when it comes to creams can be compounded at 20% testosterone. The strongest commercial is 5%. And then you've also got increased bioavailability. Beyond 20%, it comes out like sand. So 20% is kind of the max we've been able to work out how to get it to. So when you're using a cream, it's best to apply it to a shaved scrotum. It needs to be shaved because the hair will actually block the absorption. And the scrotal skin has a higher presence of the enzyme 5-alpha reductase, which is what converts testosterone into DHT. And it also is it's the thinnest skin on your body, so it absorbs better. Plus, transference is not an issue day to day unless you're rubbing your scrotum on people, which people don't typically. That's more of an issue probably. So transference risk is gone, better bioavailability, and better metabolism of the hormone. So the way that I teach people to use cream, and I've seen this play out so much, and I've seen other practitioners adopt this. So if you run a clinic, one of the challenges that you have is that you have a lot of people who are unhealthy starting TRT. Now, the problem with being hypogonadal for a long time is that it's terrible for your metabolic health, but humans are humans, and they tend to do self-sabotaging things that makes them feel better in the short term, which causes problems in the long term when they feel like garbage anyway. It's a human behavior. So a lot of the time when someone comes into a clinic, the first thing that you have to assess is to go, do you actually need this, or can you just fix the habits that are messing you up and then your suppression will resolve? But in the event that they need it, the problem is that that poor state of health, maybe they've got 10 kilos of body fat to lose, maybe they need to, build a routine with no alcohol, maybe they need to improve nutrition, maybe all those three things combined. Those factors lead the body, when you inject testosterone, to increase the production of aromatase, decrease the production of 5-alpha reductase, and you tend to have this inflammatory driven process where the hormones don't deliver the profile of balance which allows them to make you feel the way you want to feel and get the benefits that you want to get. When it comes to cream, when men who are in this side effect camp of guys on injections, when they use cream, because much more of it converts into DHT, they tend to have the hormonal profile that a healthy, lean individual has, which allows their body to be healthier while they drop the body fat. So my standard approach is that when men are obese or they have metabolic syndrome, using a cream, even if they're like, oh, it's inconvenient, I don't like that, is going, well, use the cream until you drop the body fat, and then you can swap to injections if you want to. But a lot of guys who are healthy and do great with injections, they prefer to be on the cream because they feel better from the increased DHT expression. And they say that they feel the effects of the treatment more, plus they don't have to inject it. But ideally, it should be put on twice a day. You can put it on once a day, but twice a day is going to give more stability. I think at the end of the day, cream twice a day versus a baby little injection once a day, from a compliance standpoint, it's about the same. But a lot of guys will do better on the cream in terms of outcomes. And that's why I think that it should be a tool in the toolbox, and practitioners should have both available.
I was always a skeptic of creams. I've always used injectable, but I actually have some cream on its way because I want to try it. I've been on TRT for 10 years, never used creams, and I just continue to hear more compelling reasons why I should try that. I'll tell you, the biggest concern that I have is, you kind of joked about it, but I'm not rubbing my scrotum on everybody, but if I want to be intimate with my partner, I don't want her growing a beard either, right? And so what's the protocol? What's the concerns there?
Yeah, and it's a very good point. I was similar in terms of my journey. I mean, I was on injections for 6-7 years. When I moved over here to Eastern Europe, it was much easier to get cream. So I did cream for 1.5 years. And then recently I swapped back to injections because for me, I got the same levels, the same subjective outcome. Like, the only thing that was different was the application process for me. Everything else was the same. So I recently swapped back to injections to prove that point. But I often, when I'm working with guys who've been stable on it, because my general advice is pick one and get stable on that until your hypogonadism symptoms resolve. And then if you want to try the other one, try the other one. Going back to the Coke and Pepsi thing, if you love Coca-Cola, you should at least try Pepsi. Like, if you're going to drink a Coke, you shouldn't drink a Coke a day. But if you're going to drink a Coke a day for the rest of your life, try Pepsi. You might like it more. You can always swap back to Coke. So I have a lot of guys who are on one or the other, and they say, hey, I want to try the other one. And I go, absolutely. If you're going to do this for the rest of your life, try the other one for 6 months and see how you go with it. You can always swap back. And I've swapped a lot of guys from one to the other, and I've swapped a lot of guys to cream who've stayed on cream. I've swapped a lot of guys to injections who went back to cream. So I find that interesting. I also find it interesting that a lot of the practitioners who I work with use cream themselves. So I think that's also quite telling. So in terms of the transference, that's the big one. And one thing that I speak to clients a lot about, because doing the health coaching thing, I spend more time talking to people about the more logistical side of things and the questions and concerns. And if someone's like, hey, I sleep naked with my partner every night, and that's an important part of our intimacy, I go, look, that's an important thing to keep. The relationship is very important, and that's a contraindication. So that can be a factor. When it comes to sexual transference, I've seen some people who are very blasé about it. I'm always hyper conservative in my recommendations for things. So I've seen people say that after 30 minutes, no transference can occur. I think 2 hours is probably a better point to say this is going to be 100% fine. Anything before 2 hours, I just say, look, rinse off. I joked about this the other day. I said, no woman that I've ever met would ever complain if a guy said, hey, now I have to have a shower before we have sex every time. Like,
right.
Oh no, like, I don't get the sweaty balls. Like,
yeah, exactly.
So, if if you put your cream on and, the moment it rises, just wash it off, do the business. And then you would have absorbed a good chunk of it by that point anyway. And you're going to be applying another dose 12 hours later too. So, and it's the same thing, if someone's like, oh, I went to the beach, want to go swimming, over time, you kind of realize that it's just like, look, it's absorbed for an hour. I've got more than probably more than 70, 80% of it in my blood at that point. Just wash it off, put the next dose on 12 hours later and don't worry about it. But the transference is important because women need testosterone too, but they only need a tiny bit and they're very sensitive. It would be like if a woman, had progesterone and estrogen cream on her genitals and that transferred to the man, that would be a lot. And that would have a biological effect too. So I think it's always good to be safe and sorry and rinse it off. And some guys find that process and that part to be cumbersome and annoying. So do injections. But for other guys, they go, look, it's not a big deal. Have a quick shower, wash it off, sleep with underwear on, no problem. So that factor in terms of the lifestyle component is important because that's the stuff that matters day to day.
Exactly. And you said about an hour in, you're probably about 70 or 80% absorbed. Is that fair to say?
Definitely. Even probably more than that. So even if it had been an hour and you wash it off, because you're putting it on every 12 hours everywhere anyway, it's not a big deal. Nothing to worry about.
Yeah. You keep making the Coke and Pepsi reference. I'll just put my plug in for Coke Zero. Pepsi Max isn't as available here as it is in places like Australia.
I've seen that's a problem.
Yeah. But I do love me some Pepsi Max too. This is my vice. I will say Coke Zero. But speaking of obesity and things like that, when you come across somebody who is low testosterone and is carrying extra body fat, and you mentioned some of those inflammatory effects that testosterone can have in that instance, do you usually recommend them to drop body fat first? Do you recommend that, they might, as an example, use a GLP-1 to concurrently help bring that body fat down? Talk to me about that strategy.
I think this is where things need to be looked at on an individual and human level. When I was doing my speech at Silverback the year before we met, I referenced the movie Cars. And if people haven't seen the Pixar movie Cars, you've probably seen the cartoon where it's the car with the face on it, Lightning McQueen. That's a really good example of a human. We are a machine that is sentient and alive. So treating a human like a robot doesn't work. Treating a human purely as a conscious spiritual vessel doesn't work either because there's this interconnected relationship. If we were robots, my job would be way easier, because it's the decisions that people make that cause problems. Usually they're emotional. So when it comes to the body fat thing, there's this myth that if someone drops their body fat and gets lean, their testosterone will go up. If that were true, then we wouldn't have so many younger men needing TRT. I see guys all the time who are under 25, shredded, doing everything right, and they've got the testosterone, like what you said before, of the 80-year-old man. So the thing that we have to look at is saying, and this is where, again, it comes down to the individual. So the first thing I ask someone is I say, do you want to go on TRT? Because I'm a big fan of the idea that people should be able to make interventional measures with their health. If women can get boob jobs and butt implants and plastic surgery, and people are doing all kinds of elective surgeries these days, optimizing your bioidentical hormones, I think, is something that people should be able to do as long as they make informed consent and understand what they're signing up. I think the risk to reward ratio is drastically in favor of reward, but there's the compliance of the lifelong dependence, which has to be discussed. So if someone's like, look, I want to optimize my health with TRT, then I think that that's something that should be worked with. But if someone's saying, I just want to get my testosterone levels up and feel good, and if I need TRT, I'll do that, but I'd rather not have to do it if that's not the case, then I think that's when it comes down to looking deeper into the blood work. So if someone has a suppression of luteinizing hormone, which is the signal from the pituitary to the gonads, on the blood work it shows up as LH. If this is at a 2 or a 1, it means that the body is suppressing that hormone production, which means that if you resolve the thing that's causing the suppression, because the body is focusing on survival first and reproduction last, if you focus on resolving the inflammatory issue that's suppressing that reproduction signal, then the testosterone levels will come up. But if someone's in a situation where they're overweight and their luteinizing hormone level is not suppressed, it's at a 3, 4, 5, 6, or it's elevated, meaning the testicles have failed, that means that we're kind of looking at this chicken or the egg thing. And that means that we're looking at a scenario where maybe the poor diet and lifestyle habits and the low metabolism is someone having these maladaptive biological and psychological coping mechanisms for feeling terrible. And those instances, that's where it's saying, hey man, it would be great if you drop 10 kilos of body fat, but that's not going to bring your testosterone levels up. And using testosterone while you're losing the body weight, as long as there's these other methods in place to reduce the side effects, whether it's using cream, daily injections, using something to improve insulin sensitivity. Personally, I gravitate towards using metformin as well as dietary interventions like increasing fiber, things like greens powders, liver capsules, protein powders, nutrient-dense whole foods so that it can regulate appetite a little bit, and then use a little bit of metformin to improve the insulin sensitivity. That's my approach, but other people are using GLP-1s instead of metformin. The outcomes are the same in terms of reducing the insulin resistance, which basically allows the metabolism to function properly so that the body can burn fat. And not only are you optimizing the metabolism with the insulin sensitizer and testosterone together, but you're also using this agent now to reduce the inflammatory cascade, which is going to cause the side effects from the TRT. And that's why it's so important that when practitioners are onboarding clients or patients, they're looking to see, does this patient have fatty liver disease? Do they have hypothyroidism? Do they have insulin resistance? Are there these issues that we need to concurrently treat and control for so that they get the outcome they're looking to achieve rather than having side effects?
Yeah. And you nailed it on metformin. I think it's one of the most underused tools that we have in our toolbox to control a lot of those issues, right? The issue is it's not as profitable as GLP-1. So that's why it's not pushed, right? And that's a whole different subject. But you mentioned luteinizing hormone. So if mine is suppressed, what are ways, what clubs do you have in your bag to bring that up?
Yeah. So the first thing that I speak to people about, and depending on where the individual is with their self-awareness and their knowledge, because some people don't know anything about health and fitness. And it's not because they're stupid. It's because they're hyper-specialized in another field. So generally, though, I would say the majority of people know exactly what they're doing that they shouldn't be doing, and they know exactly what they're not doing that they should be doing. And if they can be taught and understand these bad habits or these lack of good habits are leading to suppression of your endocrine system, that can be the wake-up call they need to make that change and to resolve the issue. And I think educating people to understand why they need to do what they need to do, not just telling them, works better all the time. So if that's the case, it could also be about educating people to say, hey, cut the alcohol. That's the biggest one. Alcohol's the biggest issue. Cut the alcohol. If people are still smoking cigarettes, I mean, cut those out too, but less people are doing that. Alcohol, cigarettes, lack of nutrient-dense food in the diet, lack of hydration, shift work messes people up a lot, untreated sleep apnea, lack of cardiovascular training. I don't give two shits if someone controls their macros to be lean and shredded without doing cardio. You need to do cardio for heart health. So all of those lifestyle factors are the main thing to bring the luteinizing hormone up. In terms of supplements and other things that can be used, I mean, outside of a comprehensive multivitamin to address nutritional deficiencies, there's usually something going on that is the cause of that being suppressed. The problem is if it's what's called an intractable condition. So someone might have a deformity of their pituitary gland, which is scanned with an MRI, which causes that not to produce that hormone at all. Other people will have things like surgeries gone wrong, other issues going on with their health that can't be resolved. And that, or maybe they've had chemotherapy recently, things like this. And that will lead to this hormone being suppressed for a reason that can't be resolved. So that can also sometimes be the conversation to say, hey, this needs to be done. But it's so important that the practitioner has the patient's best interest at heart in terms of not just being like, oh, you qualify for treatment, here's your testosterone, see you later, to actually have the conversation to say, do you need this? Do you want this? Is this going to achieve your expectations? And how are we going to allow you to work with this medicine to meet it halfway to get the result that you want?
Much like you, I have folks reaching out, every day and they recognize that they're struggling with the symptoms of hypogonadism. Maybe they've had some blood work and they realize they're low or even below the reference range, but they're not ready. You mentioned that they're not ready. They're not ready for the creams. They're not ready to make that lifelong commitment. And so I know some clinics, some telemedicine companies using clomiphene or Clomid as a kind of a fix, kind of an intermediary step. What's your take on that?
So I am not a fan of the Clomid and clomiphene, but I am a fan of the idea that there should be something in the toolbox that fits into this category. And the problem so if someone's going to use Clomid, you're better off using N-clomiphene. So Clomid is two isomers, which is basically like if you imagine the yin and yang thing, it's like two halves make a whole. So Clomiphene is an estrogen agonist in some tissues. That has no benefit. So N-clomiphene is the part of Clomid or clomiphene that people want to do the thing that they're trying to do, which it acts as an estrogen antagonist. So it's like a blocker of the receptor in certain organs. And tamoxifen, which is the other one, Nolvadex, they have a different ratio of which organs they are more antagonistic with. And Clomid is more antagonistic in the brain, which is what people are wanting to use it for. So when you block the estrogen receptor in the hypothalamus, what this does is it basically signals to the body to say, hey, there's no hormones here. Increase that luteinizing hormone output so the testicles make more hormones. The problem is that Clomid is an estrogen antagonist in the entire brain. And the long-term use of this hasn't been studied in men. So we don't know if this is going to lead to neural degeneration. We don't know what the long-term outcomes are. But what we do know is that when people do this, their lab work tends to look better. Their numbers go up, but they don't tend to feel as good as if they'd achieved those levels either naturally or with TRT. And it's likely due to how the Clomid is also doing other stuff in their body. So when it's looked at myopically via one mechanism, it sounds great, but the drug does other stuff and we don't have safety data. And this is one of the reasons I like metformin over the GLP-1s. Metformin has almost a century of safety data. GLP-1s, none of them been around for long enough to do a follow-up study on. So I tend to go, I guess because I had my brain injury in the past and I've lost my health and got it back, I'm much more conservative with things. The thing that I think is exciting. So at the Silverback Summit where we met, I met Charlene, who's the CEO of Marius Pharmaceuticals, who make Kaisertrex. And we, at the social event, I went up to him and he came up to me and we had a chat and I said to him, I said, I think your product's garbage. And I was very honest. I'm like, I think it's crap. And he sat me down and I talked to him and his head of clinical research for at least an hour. He took me through everything. And at the end of the conversation, I said, I don't think your product's garbage. I think it actually has a use case. But what I didn't understand, because we've had andriol testo caps in Australia for years, which is the same thing, just much weaker. And the thing with Kaisertrex, which is just a stronger version of, and I don't have any financial relationship with them at all, but I really admire what he does. We've actually just brought Kaisertrex into Primal Zone in the last week. So we're going to be in Australia, which I'm really excited about, is that the limitation of oral testosterone is that it can't really bring your levels up to the higher end of what you can get with injectables and cream, but it doesn't shut your natural production down. So if someone's in a situation, and I was speaking to my friend Mimo, who's one of the head guys at Marek Health, who does a lot of their clinical stuff. And I asked him, because they'd adopted Kaisertrex, I said, why are you using Kaisertrex? What's the use application for this? This was the next day. And he said, well, if someone comes into us who would be able to recover their testosterone levels if they lost the weight and fixed the habits, but they needed help getting there, this is a better option than using N-clomiphene to increase those levels without damaging their natural production. So I was like, okay, that's cool. And then when I was having a conversation with the distributor for the product, I kind of put everything together that Charlene had spoken to me about and realized that this is a fantastic option for people whose levels aren't quite low enough that they need TRT, but they want to be able to benefit from having more testosterone in their body without shutting down their natural production. Because if they're in the absolute gutter, that oral testosterone working out of your system overnight wouldn't be beneficial. It wouldn't allow for symptomatic resolution. But if the baseline level is still halfway decent and someone's wanting to have, I mean, I think a lot of men are like, I want to have more testosterone, but I don't want to shut my natural production down. I'm like, good. That's a good mindset to have. This could be, it's basically an oral soft gel. It looks like a fish oil, but it's in a white soft gel. This would allow people to take exogenous testosterone without shutting down their production, without potentially complicating their fertility, and also not becoming dependent on it. So I think that what people are using enclomiphene or Clomid for is what they should be using Kaisertrex for. And that, I think, is extremely exciting for the industry.
That's gold. That's gold. You mentioned one thing that is also objection to getting on HRT or testosterone replacement therapy, which is fertility. And people are concerned that if I do this, I'm not going to be able to have a family. Talk to us about, is that a legitimate concern? And if it is, if I'm going to try to conceive with my partner in the next 6 months, as an example, what protocol should I follow in order to make that happen?
Yeah, this is a really important question. And I often joke that when I'm speaking to my wife or my mom about, my career and my work, they measure my success by how many fertility protocols I've helped with. And it's, if I say, look, I worked with all these patients, or I did this deal, or I did this, they're like, yeah, cool. And I'm like, we had a positive conception today. They're like, that's amazing. So it's, I take it very seriously, because if people want to have kids, that's probably the most important thing to them in the world. So for the first 3 or 4 years of my career, I didn't speak about it because I wasn't 100% sure about how this stuff played out. And I didn't want to give the wrong information that people were going to base their, future families on. But what I found in practice, so when I first started, and it might have been similar when you first started, there was this theory that if you ran either HCG concurrently in a low dose, or maybe used it in pulses, every year or a couple of times a year, it meant that you could either keep your fertility active, or if you ran a fertility protocol 5 or 10 years later, it means that you'd get a better response because your testicles hadn't been dormant for a long period of time. And when I heard that, I'm like, well, that makes sense, because that's like a low cost insurance policy. And that seems to be, that makes pragmatic sense in terms of mechanistic theory. What I found, though, is that most guys who wanted to have kids, they'd been taking steroids for 10 years, they'd been taking TRT for 10 years, they hadn't done any of that. And when we ran the fertility protocols, the intermittent or ongoing use of HCG wasn't a variable in the success of the protocols at all. It didn't make a difference. It worked. So when I was at the first Silverback Summit and we were on stage and, Ali asked me to help with the questions, I asked all, my colleagues on stage, Dr. Jordan Grant, who's a urologist, Dr. Eric Serrano, all these fantastic doctors who've worked a lot with this as well. And I said, does the use of HCG make a difference to whether a fertility protocol works for a patient who's been on TRT long term? Because I found it hasn't been a variable. And they said the same thing. They said, nope, it doesn't seem to make a difference. So when it comes to TRT, one of the most common misconceptions is that it's male birth control. If it was, this would be unbelievably popular for that. It would be the best male birth control ever. A lot of guys think it's male birth control and they end up becoming fathers. I know guys who've conceived on a gram of tren, all kinds of steroid cocktails. They think because their balls are atrophied. Nope. They conceive accidentally first time. In the literature, and my friend Dr. Adam Hotchkiss brought this up at the summit, he said that in the literature, and I checked this, which is correct, it's about a 50-50 split of whether guys will become infertile on TRT or maintain their fertility. I have not been able to find a variable as to which, category you're going to fall into. I joke it's whichever one you don't want. So if you want to keep your fertility, you'll lose it. And if you want to be different contraceptive, you'll stay fine.
Right.
But it is about a 50-50 split. There does tend to be a slight reduction in sperm count. FSH does go to, get shut down. But there must be some kind of backdoor pathway, because I have guys come to us all the time for fertility protocols and TRT. Sperm count's already through the roof. Don't need it. But if someone's in a scenario where they're like, I want to have kids in the next, let's say 6 months to 5 years. The conversation I tend to have is saying, if you want to do it in the next 6 months, start your TRT after you conceive. Just don't complicate a process that's already complicated, because there might be something on your wife's end that she needs to sort out. 6 months, put it off. But if we're looking at more than 12 months down the line, my approach based on using, and I've published this fertility protocol for free on YouTube. It's called Beyond TRT. I've got a $29 ebook that people can pick up and read it, but it's HCG at 250 units a day and FSH, bioidentical FSH, 150 units 3 times a week. This brings the FSH back up to like a 4 to 6, which is what it would be naturally if someone's fertile. And then because that side of the cascade is already covered, we can just use the minimal effective dose of HCG, 36-hour half-life, which basically saturates the luteinizing hormone receptors at 250 units. So HCG 250 a day, FSH 153 times a week. And there's a bit of a whoosh effect in terms of the life cycle of sperm. So it's kind of like push starting a car. After about 4 months, people reach maximal sperm count. So if they run a sperm count after 6 weeks, they might go, I've only got 1 million sperm, like it's not working. It's going, no, there's a delayed effect. Anything at 6 to 8 weeks is positive. But a lot of the time the guys will, I never see a follow-up sperm count. I see a photo of a positive pregnancy test, right? Because they need 1 sperm to conceive. So the thing with the fertility stuff that I come back to though, is that a lot of the time guys don't want to assume any potential risk. And I don't ever give false promises for something so serious, but I've never seen this fail. The only time I've seen it fail is if someone was so unhealthy or they had severe testicular trauma that they wouldn't be fertile, or they were too old and that window had closed. But in the case where the individual should be fertile if they weren't on TRT, it always restores it, because basically we're bringing back the biological environment of the testicles as if they weren't on TRT, but then they get to maintain the healthy testosterone levels, which allows them to have the positive epigenetic expression. Healthy parents make healthy kids. Everyone knows that. And that's also well, studied in the research. So if guys are wanting to be fathers in the future, it's not just about getting your wife pregnant. It's about being a father. And, I joke that every man can be a brother. Not everyone can be a father. And if you're in your mid-20s and you can't even look after yourself because you have debilitating hypogonadism, you can't look after a family, and you're not going to be, like, that relationship is not going to survive, and you're going to be fucking miserable. So you have to look after yourself before you look after other people. So if you're wanting to conceive down the line, get yourself into the position that you can be the best possible father and the best possible husband, and then cross that bridge if and when it comes to it. But it's very easy to do, and the process works very well.
I love that. I love what you said about fatherhood. I think that I'd love to have you back on and we can talk about that. I tell people look up to me and they ask me about, masculinity and things. And I always tell them, look, before you lead others, you have to lead yourself. You have to lead yourself. And if you can't do that, then don't try to start companies. Don't try to, get in relationships. You have to lead yourself first. So I know you're big on that. We should definitely find time to talk a little bit more about that. But staying on the vein of testosterone, one thing that, I see frequently actually with clinics is they'll test total testosterone levels, but they won't test free, which I think is slowly kind of becoming a dinosaur, but it's still happening out there. Talk about the importance of free. And if I am bound up, if my total testosterone levels are bound up, how can I free that testosterone up?
Yeah, we'll definitely do a part 2 and talk about the masculinity stuff, because I think that's such an important conversation to have. And hearing that stuff when I was in my late 20s completely changed the trajectory of my life. And I think that's a really powerful message. When it comes to the testosterone and free testosterone thing, it's basically 2 parts of a whole. So total testosterone is a measure of either how much testosterone your testicles are producing or how much you're taking exogenously. And free testosterone is a measurement of how much testosterone is unbound to binding proteins, which is sex hormone binding globulin, SHBG, and then there's another one called albumin. So there's only a small percentage of the testosterone that's free that's circulating at any one time. And hormones don't do anything until they activate the receptor. So if you've got a bunch of testosterone, but it's all bound up, then at a receptor level, which is the level that does the stuff that impacts you and how you feel, you're actually going to be deficient. So one of the things that I do is, so in the US, sometimes the lab will measure a direct free testosterone, meaning that in the lab panel, when you get the blood taken out of your arm, they're measuring how much free testosterone was there at that time. The thing is that when someone's got natural production present, that can fluctuate like the wind, depending hour to hour, day to day. So in Australia, when we run free testosterone, they don't actually pull it from the blood. It's actually a calculation based off the total testosterone, SHBG, and albumin. And people can go online. Like if a lab's measured your SHBG, albumin tends to be pretty similar from person to person. But if they're measured total and SHBG, people can just put it in a calculator and get their free testosterone from that. So it can be calculated, but it should also be measured in my opinion. But if I have the direct free testosterone, I actually calculate it as well, because sometimes there's a discrepancy between the two, and the calculation is more of a representation of a 24-hour average of what that's going to be. So I like doing a lot of testing. I'm big on test, not guess. So if someone's going to make the decision to shut down their natural production and go on hormone replacement therapy for life, I like to be thorough. So a diagnosis for hypogonadism cannot be made without either ideally a calculated free or at least a direct free testosterone, as well as the SHBG in total, so that we can actually have an understanding, because a lot of the symptoms of low testosterone, low libido, anxiety, depression, poor sleeping, low motivation, lack of muscle mass, too much body fat, that can be caused by a lot of stuff. So it's very important that people get a really good measure of where the testosterone's at, so that we can say, do the levels match the symptoms, and is this the most likely root cause of what's going on, so that way they're making informed consent, which I think is the most important thing.
Are there any arrows in the quiver to, let's say your total test levels are, we'll call it, at a decent level, but you're still kind of bound up. Is there anything that you can do to free that up?
So the thing that often gets promoted for that is boron at 10 milligrams a day, which is a trace mineral. The problem with that is that the RDI for boron is about 3 to 5 milligrams for a man. So if you take 10 milligrams of boron, it will push the SHBG down. But then what people don't talk about is that in the later stages of the studies, the body just starts to hyper-excrete the boron and the levels go back up to where it was. We're not able to use minerals as linear inhibitors of biological functions. It doesn't work that way. Otherwise it'd be great. So when it comes to elevated SHBG, it goes up with age. So one of the factors is that if someone's older and their SHBG is higher, then that's something that's just a result of father time. But there can be insidious factors that lead to an overproduction of SHBG. Like when a guy comes in with an SHBG, that's got 3 numbers, like over 100, then usually there's something causing that. And the most common causes are liver disease. But the other one that's quite common is prolonged severe caloric deficits. And, this is one of the reasons why if you go into a cut for ages, you lose your libido, because all your hormones get bound up, your thyroid function goes down. So the other thing is that if people are doing ketogenic diets or carnivore diets, and they're not cycling out of deep ketosis by either overfeeding on protein or carb cycling, that prolonged deep ketogenic state will also drive up SHBG. So the first thing I ask people, because I can see their liver panel if they're drinking alcohol, you can see that pretty clearly. But the first thing I ask people, who have high SHBG is, are you doing a ketogenic or a low carb diet? And if the answer is yes, it doesn't mean that they can't have that lifestyle, but they just need to, either increase their carbohydrate intake a little bit or increase their protein intake a little bit, so that they're not in that deep ketogenic state all the time. So that it's something that if there's something wrong, it can be resolved. But a lot of the time, the SHBG is impacted by genetics. Some guys will have it at 20, some guys will have it at 60. And if you're healthy, because it's the free testosterone and free estrogen that create that feedback at the hypothalamus we spoke about before, if you're healthy, the body will push over that. So the total testosterone will be higher, because that's not being limited by the feedback loop of the body. So if the free testosterone's low and the SHBG is high, it's not just a matter of cutting the SHBG down. It's saying your body should be able to work with this if there's not some kind of insidious underlying factor that's leading it to be elevated.
Got it. No, that's great. Listen, I could talk to you about this stuff literally all day, but I know you've been really generous with your time. I just have one question, and you mentioned it, at the top of our show. But you're an OG. You've been around the peptide world, and now it's all the rage. I've been using peptides for over 15 years now. But what are some of your experiences? What are your favorite peptides, if you have any? I'm just curious because you've been around the industry a long time.
So when I first had my when I was kind of seeking the final resolution for my brain injury, once I'd been doing a lot of rehab and kind of got back on my feet, I booked in with this doctor who did stem cell infusions, IV stem cell infusions. And at this point, I was working 3 days a week for a not-for-profit on minimum wage, just kind of getting back on my feet. So I had the appointment with him, and the first thing he says is he goes, "I'm not giving you an IV infusion." I'm like, "Why am I here?" And he's like, "I'm booked out for 6 months, but I had what you had." And I'm like, "Really?" Because I'd never met anyone who'd had this. And he goes, "Yeah, I've had what you have." And he goes, "A stem cell infusion will fix it, but you don't have the money for that." And I'm like, "No, I don't, but I'll get a loan." And he goes, and he takes this piece of paper and writes down BPC 157 and gives it to me. And he goes, "I can't prescribe this for you, but this will give you 70 to 80% of the effects of a stem cell infusion for something you can afford." And then he didn't charge me for the and sent me out. And that was one of the pivotal moments that made me want to really help people as much as I could with, giving my ebooks away for free and putting content out online, because, someone, took some sympathy and went above and beyond to help me out with that. So when I did the rehabilitation, process, I synergized the BPC with perfect diet and lifestyle, all the essential nutrients the brain needs to heal, and very intense rehabilitation. And that's what allowed the nerve to heal. When I went to the doctors originally, they said, "You can't heal a nerve." And that's what I went back to university to learn how to fix. And stem cells seem to heal nerves. So BPC was fascinating because when he suggested this, it wasn't on my radar. This was back in like 2017 or 2016. And I found one place in Australia who would prescribe it to me, but BPC is absolutely fascinating as a regenerative and restorative peptide for the body. But my friend Jay Campbell has this fantastic approach to it, which is completely correct, is that BPC is a signal to tell the body to heal itself, but it won't heal you unless you're giving it the right inputs. So you have to have health promoting practices to allow that stem cell signaling to take place. So I think BPC is the most beneficial peptide in the toolbox because it's bioidentical and it's the most applicable for a bunch of problems that can't really be fixed or solved by anything else. So I like BPC the most. I think thymosin alpha 1 is underrated. So thymosin alpha 1 is prescribed in some countries for hepatitis. It's the most, a lot of the time people are looking for BPC or TB500 to act as an anti-inflammatory. They do a little, but they're mainly for healing. So thymosin alpha 1 is a much more potent anti-inflammatory, and stem cells and inflammation don't work well together. So a lot of the time, if someone's in severe pain and issues and they've got a situation which they're working on healing with physical rehabilitation and all these different things to allow the body to heal, I really like the combination of BBC and thymosin alpha 1 together, because I find that when you reduce the stress and the inflammation on the body, people tend to feel a lot better, because inflammation from chronic pain makes you feel terrible. And so that can really help with compliance for the rehabilitation and the nutrition and for the sleep and all of these things. But it also has a really good safety and track record because it's been used traditionally a lot. I think TB500 is also interesting, particularly as a synergy with BBC 157. And I look at it kind of, in Australia, when we talk about pies, we mean a meat pie. We don't mean an apple pie.
I recognize that now. I've had them. Yep.
So I think of BBC as the pie and the TB500 as a tomato sauce, or the ketchup, as Americans say.
Good.
It makes the pie better, but you can still have the pie on its own. So I like that combination of those three peptides. When it comes to the growth hormone peptides, I think of growth hormone as a peptide. I mean, technically it is. And I think real deal growth hormone is the best. I think those secretagogues really they only exist because growth hormone is expensive. If growth hormone was cheap, there wouldn't be a market for the secretagogues. So, ipamorelin is a budget way to increase growth hormone production in terms of it's the cleanest of the growth hormone peptides. But I think growth hormone, I think, is phenomenal, underrated, overpriced, but if it was more affordable, then I think it would be phenomenal. I think a lot of people are seeking out general health promoting benefits of peptides. They're looking for growth hormone. But when it comes to working alongside a good nutrition, hormone, and rehabilitation protocol, putting the work in, the combination of BBC, TB500, and thymosin alpha-1 is miraculous in terms of the effects that you can get for the price that you spend and the safety profile that they have.
Couldn't agree more. Brother, so many pieces of gold in here. This is awesome. I would like to have you on. I would like to talk more about masculinity, but we'll schedule that. In the meantime, how can folks find you?
Yeah, absolutely. Would love to do a part 2 when you're back from your trip. So people can find me. My website is advancedfundamentalhealth.com. I have 3 ebooks, TRT 101, TRT 102, and Beyond TRT. If anyone has made it to the end of this podcast and is financially struggling, just send me an email and I will be happy to send you the ebooks for free. Otherwise, they're very affordable, $29 Australian each. I am on YouTube everywhere. If you search Dave Lee TRT, I'm on everyone's channels, but I've recently started doing a lot of work on my own channel, and I'm releasing masterclasses. So courses that I originally made to sell, I decided to put them on YouTube for free. So I've got 90-minute lectures that are designed for patients to be able to understand everything that I possibly know about the field. And I'm releasing more of those as time goes on things like pregnenolone, DHEA, thyroid ones going out very soon. It'll probably be out in the next couple of weeks. Supplements, everything that people need to know. And then I'm also on Instagram at I'm Dave Lee. And if people want to work with me one-on-one, that's where you can find my details to book a consultation.
Yeah, and we'll put all the links below. But brother, I just want to commend you. Just putting out value. That's what it's all about. Helping folks, raising the bar in this space. It's so important. So I really do commend you. Thanks for being on.
Thanks very much for having me.
All right, folks, that's another episode of Unscripted. Tune in to the next one, and we'll bring another world-class guest for you. Thanks for tuning in.